Hello, everybody. My name is Dr. Rakesh Jain, and it's my pleasure to welcome you to this session titled Depression Neurobiology and Treatment, the Role of Gaba and Neurosteroids. This activity has been supported through an independent educational grant from Sage Therapeutics Incorporated. While I introduce the speaker for this session, if you haven't already done so, please take a moment to answer the polling questions. You should see them on your screen. Depending on the device you're using, the questions will either appear to the right of the live stream or below. These questions will be asked again at the end of the program. We appreciate you answering the polling questions. It is my pleasure to introduce our speaker for this session, Dr. Vladimir Maletic. Dr. Maletic is clinical professor of psychiatry and behavioral sciences at the University of South Carolina School of Medicine in Greenville, and is a consulting associate in the Division of Child and Adolescent Psychiatry at Duke University in Durham, North Carolina. You can type in your questions for the presenter in the Q&A box to the right of the screen, as well as upvote questions submitted by other attendees if you want to see their questions answered. We will try to answer all of the most popular questions with the time remaining at the end. So without further delay, let's begin the session.
Hello, my name is Vladimir Maletic. I'm clinical professor of psychiatry and behavioral science at the University of South Carolina School of Medicine in Greenville, South Carolina. Topic of our conversation today will be depression, its neurobiology and treatment, with particular focus on the role of GABA and neurosteroids. These are my disclosures. Disclosures related to CME, our learning objectives. And let us start with the state of the art. Where are we in treatment of a major depressive disorder? I would say that these findings, although at this point they may seem dated, because they're from data that was published about 15 years ago, unfortunately, not enough has changed in the landscape of treatment of major depression that would make these data obsolete. So there are both positives and negatives. Let's start always with the positives. Study 12-week treatment using an SSRI. How did patients fare in this study? Well, on the positive side, about 60% were in remission or experienced only mild symptoms. On the other hand, there is a flip side, and that is that about 40% had moderate, severe, and very severe residual symptoms, which would have clear implication not only on degree of suffering in these individuals, but their functioning. And as we know, major depressive disorder is not a condition that only impacts individual. It impacts the entire social grouping. So these patients will have families and coworkers and friends who will be impacted by presence of these residual symptoms. Unfortunately, this is not the end of the story. This is just the beginning, because it is one thing to help patients achieve remission. It is a completely different challenge helping them sustain that remission. And the information that comes from STAR-D does not leave us filled with optimism. Namely, although remission rates drop off steeply after first two steps in STAR-D, it is even more concerning that retention of remission is lessening at a more rapid pace. So level one, about 37% of the patients are attaining remission. But by the end of first 12 months, roughly 1/3 of these individuals are no longer in remission. Step two, they're at about 31% remission rate. But by the end of first year, about 60% of those who are in remission no longer maintain that status. And it gets worse and worse. Levels 3 and 4 less than 5% of these individuals who were capable of achieving remission in step 3 and 4 are maintaining it for more than 12 months. So not only is it a high bar to bring patients to remission, it is even a more daunting challenge to help these patients sustain their remission for at least 12 months. And as we know, in treatment of major depressive disorder, which is for the most part recurrent illness, that is actually the important benchmark. And then to go on with concerning information, steps 3 and 4, we've seen that achieving remission is not easy. Maintaining this remission is even more challenging, but here is data that puts it into the proper context. And that is in steps 3 and 4, twice as many individuals discontinued due to adverse reactions than benefited from these more advanced treatment strategies, often utilizing combination of antidepressant agents. So adverse reactions are going to be the limiting step. Majority of the patients are going to be stopping because they can't tolerate these regimens. So what has gone wrong? One potential explanation is these individuals may be neurobiologically different, but there are some other concerns in terms of our current practice. And that is that in this national survey, it was noted that about 8.5% of US population suffers from a major depressive episode. Now, how many of them actually sought treatment? That is astounding information. Barely a quarter, less than 30% of these individuals who were deemed to be depressed actually pursue treatment. So the major barrier is getting patients to treatment, period. And then what happens once they enter treatment? Well, nothing too good. 6 months later, only about 1 in 5 have followed healthcare providers' instructions. So 4/5 are no longer following the directions and maintaining treatment adherence. Half of them in 6 months have completely stopped treatment. And the part that is really concerning and I think important to note is of the ones who stopped treatment, 90% did not inform their healthcare providers. So I'm done, but I'm not going to bother giving you a call. They're just gone. Is there something wrong with our treatment approach? And the answer is maybe. But what we have to acknowledge is that major depressive disorder is not a singular entity. Major depressive disorder is highly heterogeneous in terms of its underlying neurobiology. Our working assumption for 6 decades has been that there is something wrong with monoamine transmission in individuals suffering from major depressive disorder. We utilize agents that boost monoamines, primarily serotonin and norepinephrine, and that results in improvement. This theory would not explain why it takes 3 to 4 weeks to achieve an optimal response, nor would it explain the numbers that we just shared. Why are there so many people who don't respond well and who cannot maintain remission? Well, part of the answer may be studies that looked at norepinephrine and serotonin metabolites in cerebrospinal fluid of individuals suffering from major depression. So this is about as close as we can get to brain. Obviously, we cannot be doing brain biopsies in living individuals. It would be completely unwarranted and unethical. So what do these studies about monoamine metabolites in MDD tell us? Number one, there is significant scatter. Data are all over the place. But then there is a bottom line. And bottom line is in these meta-analysis that included 11 separate studies between 400 and 425 patients. There is no difference in serotonin and norepinephrine metabolites in cerebrospinal fluid between individuals affected by major depressive disorder and the ones who are healthy controls. So CSF data really do not support hypothesis that majority of depressed patients have dysfunction or lack of monoamine signaling. We also have to be concerned about other consequences of depression. So this is not only a brain disease, this is a mind-body disease. It impacts HPA axis activity, so endocrine regulation. There's evidence that it also impacts thyroid and other steroid signaling. There is abundant evidence that would suggest that immune function, especially inflammatory regulation, is off in individuals suffering from major depressive disorder. And finally, autonomic dysregulation is part and parcel of major depressive disorder in a significant number of these patients. So if indeed there is a mind-body perspective and mind-body dysfunction, would there be morbidity that is associated with it? And if you just draw a diagonal again, across the left portion of our slide, look what happens with metabolic and cardiovascular functioning. The risk of heart disease, diabetes, and obesity is 60 to 80% greater in individuals who suffer from major depressive disorder. These are not small numbers. Mortality, 80% greater in this meta-analysis of longitudinal studies in MDD. But beyond that, MDD also increases risk for cancer, any kind of disability, 70% increase in risk, and a substantial 80% increase in risk of cognitive impairment. So definitely a mind-body condition associated with greater mortality, according to some studies, about 10-year reduction in life expectancy. So it really behooves us to address all aspects of this disorder. There has been a lot of discussion about time of onset of major depressive disorder. There is one specific form of major depressive disorder that affects a significant number of women. So in the past, it has been called postpartum depression. More recently, it is called peripartum depression. Is it in any way different than major depressive disorder? Well, it's really a difficult question to answer because major depressive disorder is not a homogeneous category. So I would say that DSM-5 does not differentiate major depressive disorder for peripartum depression, aside from specific circumstances of its onset. So by definition, peripartum depression is a depressive episode that meets DSM-5 criteria, but it occurs either during pregnancy or within 4 weeks after delivery. So let us look at some epidemiologic data that may be relevant from the clinical perspective. Why peripartum? Why not postpartum? Well, it defines it in relation to childbirth. And it has been noted in recent epidemiologic studies that 25 to 50% of postpartum depressive episodes actually start before childbirth. And therefore, it is not appropriate to continue calling it depression that starts after childbirth. How often is peripartum depression noted altogether? Well, data indicate that between 13 and 20% of women will have depressive symptomatology after childbirth. Again, the concerning part is anywhere between 40 to 70% of these women who may be overwhelmed actually do not seek help. Why is that concerning? Because peripartum depression is associated with very high suicide risk, with very severe symptoms, with a lot of anxiety. So what is the key? The key is rigorous screening. Let's pay attention. Let's ask questions during prenatal visit, during the child visits later on, around the childbirth. It is not only physical condition of mother that is so important and child. Uh, her mood state is equally important. What do what do we know about neurobiological underpinning of peripartum depression? Well, there are genetic factors that are predisposing, and then there is stress. Now, how might stress contribute to pathogenesis of peripartum depression? Well, we see that there is increase in progesterone and allopregnanolone that peaks about 40 weeks into the pregnancy. And then there is the most significant hormonal upheaval that a woman will ever experience. After childbirth, there is a dramatic drop off in both progesterone and allopregnanolone levels. Why would it be important? Because progesterone and allopregnanolone both regulate the activity and expression of GABA receptors. And GABA receptors and their activation in turn regulates HPA activity. And we know that hypothalamic pituitary adrenal response is a biological marker of stress. And therefore, women in peripartum period, due to changes in allopregnanolone and neurosteroid and GABA A transmission, both tonic and phasic, we will say much more about this in just a few minutes, do not have adaptive response to stress, and therefore one of the more frequent precipitants of major depressive episode may be in play. Again, there are genetic factors also involved. So what is our key learning point? Well, the major point is that 25 to 50% of peripartum depression is not really postpartum because it starts before childbirth. So now let us put it into a clinical context. Anna is a 32-year-old married female, 3 weeks postpartum. Her OBGYN referral for treatment of depression was precipitated at last 6 weeks of gestation. What is Anna sharing with us? Well, she's feeling really sad and tired most of the days. So again, this is before childbirth. Waking up often during the night, she's not enjoying life. Enthusiasm is diminished. She has lost all interest in work and hobbies. She does have another child, and she has to make herself play with this other child. She and her husband have had marital problems in the past, and they believed, as many couples do, that having a baby will bring them closer together. Anna is also concerned about her appearance and the fact that she has gained some weight. She's very anxious and irritable. So clearly multiple sources of stress associated with compromised functioning and typical depressive symptomatology. She has had 3 previous depressive episodes. By the way, this is common. Many of the women who have postpartum depression have had previous depressive episodes, including one after her previous pregnancy. Her daughter is now 5 years old. That is the child that she has to push herself in order to pay attention to her, play with her. Past episodes did respond to a combination of SSRI and psychotherapy, but unfortunately there was weight gain, there were sexual adverse reactions, and Anna would very quickly cut the treatment short. She's currently ruminating about her weight gain and also fearing that she may lose her job unless she can get it together. She's also concerned that her husband may divorce her. Her PHQ-9 is 21, indicating very severe depression. MDQ, Mood Disorder Questionnaire, is negative, indicating that it's most likely not bipolar, a very important differential at this point, because about a quarter of peripartum depressions are actually associated with bipolar disorder. And Edinburgh postnatal depression scale score is 18, again, reflecting severity of her depression that was also noted on PHQ-9. So let us see the possible role of GABA signaling and neurosteroids in pathophysiology of depression. We have to start our story at the beginning, and we will try to connect this with monoamine theory of depression. So first, we need to understand three major groups of GABA interneurons in the prefrontal cortex. The way they're identified is either by receptors that these GABA interneurons are expressing, or other peptides that these GABA interneurons also express. So which receptor is it? It is a serotonin 3 receptor identifies a subgroup of GABA interneurons. Another very dominant group is identifying by co-expressing somatostatin. So these are called somatostatin GABA interneurons. And the third group are so-called parvalbumin expressing GABA interneurons. Do they have a relevant role? Well, 20 to 30% of all neurons in the prefrontal cortex are GABA interneurons. The only ones that are more common than those are pyramidal glutamatergic neurons. So these are the two major populations of neurons that provide information processing in the prefrontal cortex. Now, here is where things get interesting. Monoamine, serotonin, dopamine, norepinephrine have receptors on these GABA interneurons and pyramidal neurons. And their main role is actually modulating their relationships. How will these GABA interneurons relate to each other, and how will they interact with pyramidal neurons? In other words, they determine how information will be processed in the prefrontal cortex, and all sorts of emotional and cognitive processing in these critical brain areas. So let us now pose a question. Number one, what do these GABA interneurons do with pyramidal glutamate transmission in the prefrontal cortex? They function in very different ways. In some ways, it is similar to our parents' radios and the radios that we have seen in our childhood. Those are the ones that have two knobs, and one adjusts the station, so signal to noise ratio. GABA interneurons that regulate signal to noise ratio are somatostatin expressing GABA interneurons. So they are signal to noise ratio, they regulate input into pyramidal glutamate neurons. What regulates the output of pyramidal neurons are parvalbumin GABA interneurons. And all these interrelate with each other. What is the consequence of dysfunction of somatostatin interneurons? The consequence is that glutamate output from prefrontal cortex is compromised. And where does this glutamate output from prefrontal cortex go? Well, it goes to amygdala, where it regulates processing of emotional information of negative valence, amongst others. So fear, depression, sadness, anger, all influenced. So if the output of pyramidal neurons is off, and it will be off if somatostatin GABA interneurons are not doing their job, there will be improper regulation of positive and negative affect. Also, it impacts areas that regulate hypothalamic pituitary adrenal axis, and therefore stress response will be aberrant. It provides input to bed nucleus stria terminalis, which regulates sympathetic and parasympathetic balance in the periphery. So autonomic balance will also be off. It influences thalamus, so processing of all sensory information will be influenced. And finally, but not the least important, it impacts monoamine nuclei in the brainstem. If the pyramidal neurons do not have appropriate output from prefrontal cortex, it will appear as if there is dysfunction of monoamines. I think you're getting the idea. So if the cascade starts either with somatostatin, GABA interneurons, or with dysfunction of pyramidal neurons, and these are intimately related, the outcome may appear that monoamine signaling is dysfunctional. That is really important take-home message from this whole discussion. Why call them neurosteroids? Well, two reasons. They're steroids because they have cholesterol ring as its basis. Neuro, because they are actually synthesized by neural tissue. What do I mean neural tissue? By number one, neurons, predominantly glutamate neurons, but also by astrocytes, oligodendroglia, and some evidence even suggests microglia. How are they different than other steroids? Other steroids have receptors inside the cell. Neurosteroids primarily impact receptors that are expressed on the surface of the cell, in particular, GABA A receptors, a dominant population of GABA receptors where they act as positive allosteric modulators. So they are rheostats, if you wish, biological dimmers that regulate GABA signaling through GABA A receptors synthesized by neural tissue. How are they similar or different from benzodiazepines? Because we know that benzodiazepines also modulate GABA A receptors. They, to a degree, overlap. So both benzodiazepines and neuroactive steroids will modulate intrasynaptic GABA A receptors. Intrasynaptic GABA A receptors have to do with so-called phasic signaling. So some major event has taken place. We need to have a new balance between brake and gas. So between GABA signaling and glutamate signaling, GABA via intrasynaptic GABA A receptors is bursting and maintaining that balance with glutamate signaling in order to allow for unencumbered processing of information. But beyond that, there are also GABA A receptors that are located outside the synapse, extrasynaptic GABA A receptors. They regulate basal tone, basal release of GABA. So they regulate the threshold. How will we be on ongoing basis responding, and what is our threshold to respond to a stressful event? That is regulated by extrasynaptic receptors. These are not amenable to benzodiazepines. These are only influenced by neurosteroids. Let's look at this story in a little bit more detailed way. So we see that GABA A receptors are grouped around chloride channel, and they have 5 subunits. In physiological circumstances, in intrasynaptic GABA receptors, we have alpha, beta, gamma units, and benzodiazepines like to bind close to alpha 1 subunits. In physiological circumstances, this is important. And we also see that neurosteroids bind at a different place on this GABA chloride channel receptor unit, but they both have an impact on how this receptor works. Steroids modulated in a positive way, so the benzodiazepines. On the other hand, when it comes to extrasynaptic GABA A receptors, instead of having this gamma unit, they have delta subunit, and benzos don't bind to GABA A receptors that have delta subunit. Therefore, they have no role in regulating basal GABA transmission, tonic GABA transmission. Now, something curious happens when one is exposed to protracted, chronic, ongoing stress. And that is the most frequent precipitant of major depressive disorder, one of the most frequent, as you know. Well, the composition of intrasynaptic GABA receptor changes. And instead of expressing a lot of alpha 1 and alpha 2 subunits, they start expressing alpha 4 and alpha 5. What does that mean? The affinity of that GABA A receptor for benzodiazepine diminishes at the time when you would most need their benefit, because they no longer bind, they barely bind to these intrasynaptic receptors. On the other hand, affinity for neurosteroids increases. So not only are neurosteroids more effective in regulating GABA A signaling intrasynaptic in situation of protracted stress, but they also regulate basal GABA tone, which benzos do not at all. Therefore, they may be a more successful strategy in addressing some conditions related to chronic stress, such as MDD. Let us look at what these neurosteroids do across multiple neural cell lines. So when it comes to astrocytes and microglia, neurosteroids will actually diminish inflammatory signaling. When it comes to neurons and neuroblasts, neurosteroids will provide better survival rates and greater neurogenesis of neural tissue. And when it comes to oligodendrocytes, neurosteroid-mediated signaling will promote myelin repair. So these long white tracts that connect brain areas relevant for emotional regulation and stress response. Boiled down, neurosteroids most likely have a neuroprotective effect. So what is our key learning point? Neurosteroids regulate both phasic and tonic GABA A mediated signaling, which is clearly not the case with benzodiazepines. Now, let us look at studies substantiating the role of GABA and neurosteroids in etiology of major depressive disorder. So in the recent years, we're starting to see results from major undertaking. And they have cross-referenced functional and structural imaging studies, cytological studies, transcription studies, genome-wide association studies in a large number of patients who suffer from MDD and compare them to controls. When I say large number, over 23,000 individuals who suffer from MDD. And when you cross-reference all these different data points, what is the bottom line? The bottom line is the cells that are affected in MDD, number 1 and 2, are somatostatin GABA interneurons and astrocytes. So this is cellular signature of MDD. And what we're finding is that GABA producing cells in the brain are not only neurons, they're actually astrocytes. So when we label synthetic GABA enzyme and the enzyme that breaks down GABA transaminase, and cross-stain, we find that more than half of GABA-producing cells in the brain are astrocytes. And what does GABA do? Well, look at this right side of graph. We're activating microglia and astroglia. This is, again, Petri dish type of study. We're activating microglia and astroglia with a stimulus, which is lipopolysaccharide. In either situation, the outcome is increased release of inflammatory cytokines, tumor necrosis factor alpha and interleukin-6. What happens when you provide GABA into that mix? GABA cuts inflammation in these neural cells by half. So not only is a lot of GABA produced by astrocytes, meaning that GABA is a glia transmitter, but it also has a prominent anti-inflammatory role in the brain. Do we have a more direct evidence that GABA is implicated in major depressive disorder? Well, absolutely so. And it's interesting, if we look at GABA signaling, and this is evaluated by doing magnetic resonance imaging, what we're finding out is that non-treatment resistant depressed patients, so that maybe patients in step 1 and 2 of STAR-D, don't have different GABA levels from healthy controls. But on the other hand, treatment resistant by definition have failed 20 antidepressant treatments, actually have prominent difference in their GABA signaling from healthy individuals. We're also seeing that compromised GABA transmission the more it is compromised, the earlier the onset of major depressive disorder, which we also know is a negative predictive factor. And finally, in postmortem studies that have looked at transcription of somatostatin, we're seeing that there is a 33% difference between healthy individuals and depressed individuals. Uh, uh, Anterior cingulate cortex is very much involved in emotional regulation. And therefore, it's not surprising that we're seeing that GABA signaling evaluated by magnetic resonance imaging reflects both severity and severity of anhedonia in depressed patients. We have been talking about HPA dysregulation. HPA axis is sometimes called HHPA, hippocampal, hypothalamic, pituitary adrenal signaling. Is GABA relevant for structure and function of hippocampus? Well, we're first looking at volume of hippocampus in individuals who are healthy, have treatment-resistant depression or non-treatment-resistant depression, and we're finding that indeed the ones who have treatment-resistant depression have smaller volume. But lo and behold, having low anterior cingulate cortex GABA signaling is also associated with the reduced volume of hippocampus. So no wonder that there may be issues with HPA axis activity. There's no wonder, because hippocampus is involved in immediate recall, that there are recall issues, spatial memory, where did we put things, word search strategies, also hippocampal function, being able to express yourself. All these may in part be compromised, again suggested by this evidence that low GABA in hippocampus translates into lower volume, and in many studies, lower volume equals lower function. How about amygdala? Brain area that is responsible for generating these threat danger signals and also responds to loss and with sadness. Again, what we're finding is that there is an altered expression of somatostatin in these GABA neurons in amygdala. And this is also a postmortem study. So again, there is a structural and most likely functional consequence because amygdala are altered in MDD, and again, tend to have reduced GABA function. How about this allopregnanolone, this rheostat dimmer that regulates intensity of GABA signaling? Well, we're finding that in prefrontal cortex, an area that has to do with top-down regulation of emotion, but also cognition, there is significant reduction in GABA activity, and this is GABA synthesis. So reduced GABA synthesis in dorsolateral prefrontal cortex, not in cerebellum, but in this area that is important for cognition and regulation of mood. And again, what we're finding out is that there is almost double difference, higher GABA levels in healthy controls compared to individuals who have depression. But lo and behold, even conventional treatment with antidepressants ultimately elevates allopregnanolone levels. And another study that supports that, showing that, again, cerebrospinal fluid allopregnanolone levels correlate with depression score. So the lower allopregnanolone level, the more profound depression. But they also correlate with success in treatment. If we're capable of eliciting increase in allopregnanolone, translates in better treatment outcomes. So a place where we have an agreement is in depression, there is increased response to stress, or better yet, dysregulated response to stress, which is manifest by changes in cortisol levels and CRF levels, and inflammatory signaling. TLR4 is toll-like receptors 4, which mediate some of this inflammatory response, and it is related to lower allopregnanolone levels and compromise GABA signaling. Therefore, if we can increase allopregnanolone or increase GABA-A mediated signaling, we might have a more adaptive stress response. So Anna's pregnancy was unremarkable. Again, aside from the first trimester morning sickness, she's overweight. Physical exams and vital signs are fine. She has been on appropriate dose for SNRI now for 6 weeks. And despite initial improvement, things have begun deteriorating. She's depressed even worse now. Thyroid is not an issue. Levels are within normal range. And even though we've had to have a discussion about neurosteroids, something very new, decision was made to initiate treatment with a 60-hour IV infusion of neurosteroids. We will soon see what happens. So let us review some of the research data. Well, there is a neurosteroid that is in late phase 3. This medicine is called zuranolone. And what can we see in this controlled study of zuranolone? Well, a couple of things. Number one, by first week, typical patient in the study is responder. So 50% reduction in their HAM-D scores. They're starting at about 25, and there is more than 50% reduction within first week. And the other part is significant reduction by conclusion of the study, which is just 2 weeks out. Majority of these individuals are in remission after receiving oral 30 milligrams zuranolone. How many exactly? 64% remission rate within 2 weeks of zuranolone treatment, which is more than double of what was observed with placebo. So again, very robust outcome. There are now extension studies suggesting that 70% of these individuals have maintained their remission with only 1 or 2 2-week treatments of zuranolone in the course of a year. And this is what Anna received, brexanolone, which is again, like zuranolone, these are derivatives of allopregnanolone, semi-synthetic, synthetic derivatives of allopregnanolone. And after just 3 days of treatment, there was significant improvement in women suffering from postpartum depression. There is another approach, ganaxolone is another neurosteroid, and in this open label study, it showed an early indication of response within 6 weeks study of patients. Some of them were on antidepressants, some were not. So what is the key learning point? Well, brexanolone is actually the first non-monoamine modulating antidepressant approved by FDA, and it is currently approved for treatment of peripartum depression. Zuranolone and ganaxolone are also being developed both for MDD and postpartum depression and offer different mechanistical approach to treatment of major depressive disorder. Let us start wrapping up our story with Anna. She has returned for a 2-week follow-up visit. Her SNRI treatment was discontinued because it just wasn't helping her very much. At this point, her affect is much brighter, and she reports improved mood, improved energy, sleep, sexual response, and now she has enthusiasm again. She's still on maternity leave, so she's able to enjoy time with her children. First 2 days of treatment, Anne experienced some somnolence in the morning and dizziness and a little bit of transient nausea. These adverse reactions have dissipated and abated within a matter of days. Her PHQ-9 has gone from 21 to 7, meaning that she has minimal symptoms at this point, and that is also reflected on her Edinburgh scale. So in summary, a significant number of patients suffering from MDD and postpartum depression do not achieve optimal clinical outcomes with currently available agents. Major depressive disorder is biologically heterogeneous condition, and there is strong suggestion in both preclinical and clinical study that GABA and neurosteroids are involved, and at least in a significant portion, possibly just as much as monoamines in etiopathogenesis of major depressive disorder. And we're seeing from early and preliminary data, at this point, there are even some phase 3 data utilizing neurosteroids, as well as clinical data, because brexanolone is already FDA approved and being used, that these agents may help with the subcategory of depressed patients. And with that, I will thank you and your kind attention and conclude this talk. Thank you very much.
Welcome back, everybody. And before we jump into Q&A, please be sure to answer the post-activity questions to the right side of your screen. Please click the submit button after the last question to successfully submit your answers. And as always, thank you so much for answering the polling questions. And thank you so much for such an excellent presentation, Vlad. Our audience has some great questions for you. And because we have only 3 or 4 minutes, I'm going to jump right into it. Here's question 1. Is there a specific time frame prior to childbirth that differentiates between the exacerbation of the prior depressive episode and pregnancy-induced depression?
Well, it's interesting that you're asking that question because it's just a matter of which point on the slope is the most risky one. And there are multiple factors that play into it, such as level of stress, such as genetically based resilience in a person. Here's what I'm talking about. Last few weeks of pregnancy, there is a steep drop-off, both in progesterone, in allopregnanolone. There is also an involvement of genetic regulation of GABA A receptors. So if that falls into a constellation where there's also a lot of stress, that is likely to trigger postpartum depression. Now, what is not widely known is, depending on the study that we read, anywhere between, I'm just rounding the numbers off, 30 to 50% of postpartum depression actually starts in pregnancy. And that is why the name was changed from postpartum depression to peripartum depression. Because it just depends on where on the slope. Both progesterone and allopregnanolone are dipping towards the childbirth. Is it going to happen during that time of the dip, or is it going to happen immediately after childbirth? There is a month-long window in order for it to be defined as major depressive episode with peripartum. Peripartum onset is the official language now.
Got it. That's very helpful, Vlad. And here's another question we would love to hear your thoughts on. The question is, I was completely unaware that neurosteroids interact with GABA. Can you tell us how it interacts with the GABA receptor, and how is this different from benzodiazepines?
It's an excellent question. So I know that you have developed a major interest in GABA and GABA transmission. So GABA world is full of diversity. There are many different types of GABA receptors. But for the sake of our story, GABA receptor has 5 subunits. Some of them contain gamma subunit, some of them contain delta subunit. The ones that contain gamma subunit are inside the synapse, and they're involved in regulating, if you will, the volume, the intensity of the transmission. On the other hand, the ones that contain delta subunit are on the side. They're not inside the synapse. They're so-called extrasynaptic receptors. And they regulate the threshold. What will be the basal GABA tone? Now, basal GABA tone, of course, is very important because in many ways, it translates into our basal resilience to stress. Benzos work only on GABA A receptors inside the synapse, and they are so-called allosteric, positive allosteric modulators. They are amplifiers of GABA transmission. On the other hand, the neurosteroids work both inside and outside the cell. So they regulate the intensity of transmission, being positive allosteric modulators, but they also regulate the threshold. Now, to make things even more interesting is the intracellular receptors change their composition with protracted stress. So instead of alpha-1 and alpha-2, and those are the subunits that benzos really like, we now have alpha-4, alpha-5, and gamma units are downregulated. So with protracted stress, benzos are less and less efficient. On the other hand, configuration changes, so neurosteroids become more and more robust regulators of phasic response. So protracted stress, neurosteroids have a main role. Regulation of basal GABA tone, neurosteroids have a role. Benzos have only a role in regulating intrasynaptic transmission during burst firing.
So neurosteroids are very broad spectrum for what you're saying. They are covering both elements of the stress response, the acute and the chronic and enduring. And that perhaps explains some of the enduring effects, the high remission rates, high response rates. I got it. They're very different molecules, very different. And that question was excellent. Well, Vlad, unfortunately, we are now out of time, but so glad you were with us. And thank you to the dear audience members for joining us. And to see what sessions are coming up next, please visit the live agenda page on the website. And thank you, each and every one of you, for attending this session. And I hope you enjoy the rest of the conference. Bye for now.
Thank you all. Bye-bye.